So cardiovascular risks and cardiovascular toxicity is a major issue with BTK inhibitors. It's a class effect as far as I'm concerned. Now there are certain differences between the 3 approved BTK inhibitors, and we are waiting to get more data on the newer non-covalent BTK inhibitors. So far we've seen limited evidence of cardiotoxicity with the newer agents, but it's too premature to really comment on whether or not they will be devoid of any cardiovascular issues. So we just have to wait and see. But coming back to the first generation, supposedly the older BTK inhibitors, including Ibrutinib, Acalabrutinib, and Zanubrutinib, all 3 of them have cardiac side effects, most prominently atrial fibrillation, secondly hypertension, and then in some cases ventricular arrhythmias and sudden cardiac deaths. If you look at all of these studies across the board, it appears that Ibrutinib tends to have more issues with atrial fibrillation, especially if you have a previous history of atrial fibrillation in patients who have underlying cardiovascular issues. They also tend to have more problems than patients who don't have a history of those issues. So what we're trying to do is come up with a way to identify which patients would benefit from a good cardiovascular workup more so than every other patient. So I think there is a need to risk stratify patients so that they can get the BTK inhibitors and are able to maximize their time on the BTK inhibitors and not have a cardiovascular issue disrupt their treatment. So for example, if patients are in the high risk group, and those are patients who have a previous history of poorly controlled hypertension, coronary artery disease, possibly the elderly patients, in those patients, we recommend getting a baseline cardiac evaluation with an EKG, possibly an echocardiogram, depending on their risk factors and the cardiac function. We also recommend consultation with cardio-oncology in the high-risk patient cohort, optimizing their antihypertensives. Those are common things, easy things that we can do that can allow our patients to be optimized as far as the cardiac issues are concerned. So hopefully the incidence of these potentially life-threatening side effects can be minimized and patients can continue on these treatments for a long period of time. So we're generally recommending that every patient that is being considered to start on a BTK inhibitor has a comprehensive evaluation for their cardiovascular risks, and there is no consensus as such on how and what is the best way to do that, but we've tried to do that as an opinion document with getting opinions from cardiologists and oncologists from all over the world to somehow have a framework in which we can develop these drugs and use them safely, and so that our patients can stay on them for as long as possible. And obviously with the newer agents coming through, it appears that our decisions to select a particular agent will now be based more on the toxicity rather than the efficacy, because we do feel that the toxicity across all approved BTK inhibitors, the efficacy across all approved BTK inhibitors appear to be very similar, but the distinction is really in terms of the different toxicity profiles.